Okay, my name is Tawfiq Al-Mizani from University King Saud University, Riyadh. We are conducting this webinar because of the COVID-19 reduction of medical teaching. Tonight, we are very fortunate to have two outstanding professors with us regarding the COVID-19 issues, concerns, and complications. Actually, the two professors here, not they are the most really expert maybe in their specialty, but they are famous and very advocate for medical education. Thank you very much for joining us. I will give them the mic to introduce themselves. I will start from you, Professor Mattu.
Yes, thank you very much for having me. My name is Dr. Amal Mattu, and I'm a professor of emergency medicine at the University of Maryland in the United States.
Thank you, Professor. Welcome to our webinar. Prof. Abdul Karim, mic is yours.
Yes, my name is Professor Abdul Karim Al-Mu'min, Professor of Medicine and Hematology at King Saud University in Riyadh.
Thank you, both of you, very much. We are very honored to have you with us. And I would like to say to mention one thing, that the way you deal with training physicians is really amazing. And that's why you are really continue to be adorable to all of us, you know, in emergency medicine as well as in the other specialties. Prof. Amal Mattu, you can start your lecture, please, if you can share your screen with us, and we will start.
Okay, great. Let's see. I think you'll need to enable the screen sharing.
Sure, sir. Yes, that's done.
Oh, there we go. All right. And can you see my screen now?
Yes.
The slide COVID-19 on the heart?
Yes, it's
okay,
actually
great.
clear. You can start. Thank you.
Excellent, excellent. Well, thank you all very much for hosting me. This is a real honor to be able to spend some time with you and participate in the educational curriculum. And one of the areas of emergency medicine that I have a particular interest in is emergency cardiography, electrocardiography, and also emergency cardiology. And so this area is very interesting to me. It's been very unfortunate what COVID has done to the world. And as we've learned more about the COVID-19 infection, we've come to realize that in addition to simply producing pneumonia, it does produce effects on many, many other organ systems, including the heart. And also I look forward to hearing about its influence on the hematology system as well. It's so important for everybody to understand that there's more than just pulmonary involvement. And so I'm going to spend maybe 35 minutes or so talking about the cardiac manifestations of COVID. And if there's any questions, I'll be here for a while afterwards. And also you see my email at the bottom, and please, I invite everybody to stay in touch. If there's any questions that come up afterwards that I may be able to help, please feel free to just send me an email at the email that you see. I love to get emails, and I welcome that. So with that, we're going to go ahead and get started. Just to start out with any cardiology lectures, I always just want to mention that I'm not paid by any drug companies or device companies, so this has no financial disclosures. And I'm going to begin by presenting three cases. These are very, very common cases, but these represent what we're going to spend our time talking about. And all of these are actual cases. This first case was actually sent to me by an interventional cardiologist by the name of Dr. Beal. He was working and was taking care of a 45-year-old, I think about 45-year-old man who presented to the emergency department a few months ago in the midst of all of the COVID crisis. This patient was having chest pain and shortness of breath, and this was the initial ECG. And you can see that there is significant ST segment depressions, reciprocal depressions, and huge ST segment elevations in multiple leads that any of us would look at and say, this is clearly an anterior wall STEMI. And so they immediately took the patient to the cath lab and found that the cardiac catheterization was negative. In fact, the patient had a low ejection fraction of 40%, and the patient shortly thereafter ended up testing positive for COVID-19. And in retrospect, the diagnosis turned out to be severe myocarditis. So this was not an acute coronary occlusion. And everybody was very surprised by that. The second case was sent to me by someone who asked to not be named because of the outcome. This was a 53-year-old man who called 911, our ambulance system, because of chest pain and shortness of breath. And you can see his ECG as well, very much looks like a STEMI. The computer's calling it a STEMI. There's, again, anterior ST segment elevations, maybe a little bit of reciprocal depression. And so this looks like a STEMI. So the ambulance took him directly to the cath lab from the field. They didn't even stop by in the emergency department. And when he arrived in the cardiac cath lab, the cardiologist did a history and discovered that the patient had been having some subjective fevers and a cough. And so they were obviously worried about COVID, and they presumed that this must therefore be COVID myocarditis. So they refused to do the cath, and they instead sent the patient down to the emergency department for presumed myocarditis. And they said, we're not going to do a cath until after the patient is proven to be COVID negative. Let me go back again. This was the initial ECG. When he got down to the emergency department, a short time thereafter, they repeated the EKG, and you can see that there's progressing ST segment elevation with the new right bundle branch block. And the troponins were rising, but they still said no cath until after the COVID test is negative. Well, they got a COVID-19 test that turned out to be positive the next day. And the patient continued to deteriorate. And finally, on the third day, the cardiologist took the patient to the cath lab with a positive COVID test. And it turned out that this was indeed an acute STEMI with the left anterior descending artery occlusion. And by this point, 3 days later, the ejection fraction was all the way down to 30%. And so we all have learned that time is muscle. And the longer you wait when somebody's having a STEMI, the worse their myocardial function is going to be. And this patient lost a lot of myocardium with this delay. And this was a COVID positive acute STEMI. And then the third case is very relevant to all of us, but especially those of you that may be working in the intensive care unit. This is a 54-year-old woman who had been admitted to the ICU and intubated, was COVID-19 positive. And by around day 6 or 7, she was starting to show some signs of improvement. But unfortunately, by day 8, she started showing some deterioration, developing evidence of heart failure with the falling ejection fraction. So they started her on vasopressors and inotropes, doing everything possible to reverse this heart failure. But unfortunately, on day 9, she ended up dying. And this is not an uncommon case from what we've seen in our ICUs. So we're here to talk about what exactly is happening with COVID-19. How is COVID-19 affecting the heart? I guess we were all under the impression, and I was under the impression, that COVID will produce profound pulmonary manifestations and pneumonia, leading to respiratory failure, and that perhaps leads to hypoxemia, and maybe the hypoxemia can produce the cardiac ischemia. But what we've come to discover, and this is actually something that we came to realize from early reports in the early part of the crisis from China and Italy in January and February, that a lot of these patients were not actually dying from hypoxemia. In fact, many of these patients really did not show much evidence of pneumonia on their x-rays in the first place. And in fact, many times the patients would start showing improvement, just the way we saw in this third case. They would start showing improvement, and then about a week to 10 days later, then they would start to deteriorate. So it wasn't always just a pulmonary process that was resulting in these patients' death. And oftentimes they would start to deteriorate, as I mentioned, around day 7 to 10. And this oftentimes was due to primary, and I highlight primary cardiac failure. Not secondary due to hypoxemia, but a primary cardiac problem would develop a short time later. So we've came to realize that there is a primary influence on the heart. And also what we've seen is that many of these patients have ST segment elevations on their ECGs and marked elevations of their troponins. So we ask what exactly is going on? This is not at all like what we thought about the coronavirus initially. Well, the surprise here, as we started looking into this literature, is that this is probably something that we should have already known and already expected. In fact, there's literature going back to 2004, and I cite this article even before 2004, which actually showed that during times of pandemics, major and minor pandemics in previous decades, many of those patients that had influenza, for example, oftentimes ended up dying not from the primary pulmonary problems, but actually they died from primary cardiovascular problems. And interestingly, just like in case number 3, in many cases, these patients ended up succumbing to death after about 7 to 10 days of symptoms. And so this is not new information. Many of us are surprised by what's happening to the heart in COVID. We should not be surprised because this has been reported in the literature with other types of viruses for quite a few years. So we need to talk a little bit about what the literature is showing that COVID does to the heart. Now, a caveat here is that we don't have very large studies. A lot of what I'm going to present is based on case series and case reviews and editorials. There are no 50,000 patient randomized double-blinded studies, of course, but we can surmise that a lot of the information that we're going to talk about really is true. And I'm going to start with this article. This is a fantastic review article, which will serve as the basis for which the rest of our discussion will be based. This was published a few months ago in JAMA Cardiology. And just skipping to one of the very nice figures that they had in this article, they summarized the influence of infections, not even COVID, but again, this is just viral infections in general. They summarized the influence that viral infections have on the heart by talking about 3 major problems that occur within the heart. Viral infections produce increased risk for myocardial infarction, increased risk for heart failure, and also increased risk for arrhythmias. And those are the 3 things that we're going to spend some time talking about. In particular, we'll spend most of the time talking about infarction. Now, again, what we have always presumed is that the primary way that COVID and other influenza viruses produce problems is that they produce pulmonary problems, acute respiratory distress, and that leads to hypoxia. And because of hypoxia, that ends up leading to myocardial dysfunction and perhaps heart failure, and also perhaps the hypoxia leads to arrhythmias as well. And what we've come to realize is that it's not just a hypoxic insult that leads to all of these problems. And what I'd like to do is just very briefly start out by talking about some of the problems that occur because of arrhythmias. And you can see in this chart, there's 3 major mechanisms for which arrhythmias are attributed. Number 1, myocarditis, secondary pro-inflammatory effects, and then third, sympathetic stimulation. And again, just for the sake of providing some more references, this is a very nice reference just from a couple of weeks ago, published in Circulation. And this article nicely summarized a lot of the concerns that we have with arrhythmias. Generally speaking, COVID-19 has been found to markedly increase the risk of rapid atrial fibrillation and also ventricular arrhythmias, in particular torsade. And this is largely due to these mechanisms that we've mentioned already. Ischemia and myocarditis, of course, can lead to arrhythmias. There's a tremendous sympathetic stimulation that occurs with viral infections, and that can produce arrhythmias. And then the issues pertaining to QT. And I think when your QT prolongs, that puts you at significant risk for torsade. But I think one of the really surprising things that we've come to realize is that the inflammatory effects of viruses in and of themselves can produce a prolonged QT. And honestly, that's nothing that I had ever heard of until just a few weeks ago. But significant inflammation and the cytokine storm, which is the term that's often used, the cytokine storm in and of itself, all by itself, can prolong the QT interval. And then on top of that, you start adding other medications like azithromycin or hydroxychloroquine or other medications that prolong the QT. And that can significantly lead and increase the risk of developing torsade. And that's why a lot of these patients have arrhythmia problems. So the 2 major arrhythmias that you need to be on the lookout for are rapid atrial fibrillation and torsade. And in particular, pay attention to the QT interval. If the QT is long, be very careful about any other medications that may prolong the QT. And you might make sure that their magnesium and potassium are normal, because those will prolong the QT as well. So that's all I'm going to say about the arrhythmias. I want to talk a little bit about the heart failure risk as well. And you can see, once again, looking across the top, what do viruses do that increase the risk of viral infections? Well, of course, the pulmonary influence produces hypoxia, and that's going to increase myocardial oxygen demand. There's sympathetic stimulation. Myocarditis is something that we'll talk a little bit more about. These patients are at increased risk for myocarditis, and that leads to heart failure. And then the cytokine storm, the pro-inflammatory cytokines produce myocardial depression. And again, there's that myocarditis. So there's many, many different features that funnel into producing heart failure. Well, how common is the development of heart failure? I'll refer you to this article. This was published early on during the crisis, and at least a half dozen more articles have been published saying very, very similar things in similar numbers. Just to summarize what this data has said, heart failure occurs in approximately 1/4 of patients that are admitted to the hospital with the coronavirus. And in fact, amongst the sickest of patients, heart failure tends to be very common. More than 50% of those patients that ended up dying died in large part related to heart failure. In contrast, amongst the survivors, only 12% ended up developing heart failure. So heart failure is very much associated with the worst outcomes in these particular patients. A big reason for the development of heart failure is myocarditis. And here's another article amongst many other articles that have talked about the significant increased risk of myocarditis in patients with COVID. And of course, myocarditis, the more severe it is, leads to circulatory failure. And in these articles, what they found was that the myocarditis was associated with a significant increase in risk of these patients developing evidence of heart failure. Let me see, having some, there we go. So myocarditis was considered a contributing factor in up to 1/3 of patients that ended up developing heart failure. So myocarditis occurs in many of these patients. Why exactly is this happening? I've alluded to just a few minutes ago this cascade of cytokines, or what oftentimes people are referring to as cytokine storm. Now, as an emergency physician, I don't really think about basic science very much, but I think it is still worth remembering back to your training what you learned about cytokines. What do cytokines do? The cytokines that are being produced by these viral infections. Cytokines produce significant decreases in produce myocardial suppression and also significant systolic dysfunction. There's a handful of other things that it does, endothelial dysfunction, which leads to acute coronary syndrome. But these two factors in particular that are caused by these pro-inflammatory cytokines are largely what is being attributed to the development of heart failure. So again, inflammation, which is a central process in all of the bad things that occur in COVID, produces the heart failure. The third part of the cardiac manifestations that we worry about is an increased risk for myocardial infarction. Now, this is not just the type 2 myocardial infarction, where patients that have significant stress have a bump in troponins. We're talking about type 1 myocardial dysfunction, the thrombotic causes, the plaque that ruptures and produces a thrombus formation. Why does this happen? Well, you can get direct vascular infection, and that leads to cellular inflammation. There's that word inflammation that shows up once again. Inflammation, cytokine storm, also produces plaque rupture, which we'll talk about. Hypercoagulability, which I'm sure we're going to hear a lot more about in the next lecture. And then once again, sympathetic stimulation. So there's a lot of different factors that funnel in that produce an increased risk for myocardial infarction. Again, this is not something that's new to COVID. If we go back just a handful of years ago, this is an article that was published in the New England Journal in 2018. This is before the current COVID crisis, when a lot of literature looked at just plain old influenza A and influenza B. And in this article, they talked about the fact that patients that are diagnosed with influenza A and B have a significant, a 6-fold increased risk for having a STEMI in the first 7 days after influenza. And the risk is even higher in influenza B than in influenza A. So 2 take-home points. Number one, viruses can increase the risk for myocardial infarction. And then the second take-home point we should take from this also is that not all viruses are the same. Influenza B is much worse than influenza A. And what we're learning is that COVID is much worse than either of these types of influenza. And we've been seeing many of this. So how does inflammation play into this? And back when I was in medical school, I was taught, my generation was taught that myocardial infarctions are a cholesterol disease. Patients eat bad food, their lipids rise, their cholesterol rises, and that's where plaques come from. What we now know is that myocardial plaques are not primarily the result of lipids and cholesterol, but the major risk factor associated with the development of plaques is actually inflammation, systemic inflammation in particular. That's why patients, for example, with lupus, which is a systemic inflammatory disease, lupus significantly increases the risk for developing myocardial infarction. HIV is a systemic inflammatory disease that increases the risk for this. Chronic kidney disease produces systemic inflammation, and so on. So anything that produces systemic inflammation is going to increase the risk of developing ruptured plaques followed by platelet aggregation and thrombus formation. And again, as we mentioned, COVID-19 is a tremendous systemic inflammatory state. So what does inflammation do? Well, inflammation produces vulnerability of the plaques. If you have a stable plaque, inflammation can turn a stable plaque into an unstable plaque. As the number of inflammatory cells within the plaque increases, it can produce more instability of the central core of the plaque and perhaps even thinning of the fibrous cap. So inflammation can cause vulnerable plaques to become, or rather can produce vulnerability of the plaques and can set off the process for producing a type 1 STEMI. And the other point that we need to talk about is troponin levels. Multiple studies have now come out talking about the fact that troponin levels predict badness in these patients with COVID-19. Elevated levels of troponin are a significant marker of prognosis. In these studies, they found that amongst hospitalized patients, anywhere from 15 to 20% of patients that are sick enough to get hospitalized will have elevated troponins. And amongst the ICU patients, about a quarter of them will have elevated troponins. And amongst the patients that die, more than half the patients that end up dying or go on to die will have elevated troponins. So a lot of people have looked at troponins, in other words, myocardial injury, as a marker of a bad outcome, to the point that a lot of people are routinely drawing troponins at the time of admission and suggesting that patients with elevated troponins might be better served by going to the ICU right up front. So if we could pause for just a moment and summarize what we've talked about thus far before we proceed. Again, myocardial injury is common in severe cases of COVID. Elevations in troponins are very common and prognosticate the severity of illness. And then the three major ways in which COVID-19 influences the heart is by markedly increasing the risk of arrhythmias, by increasing the risk for development of heart failure, and by increasing the risk even for the type 1 STEMIs. So I'll let that sink in for just a moment, right? Now, let's move forward a little bit and let's talk about, well, what do you do now? When you're taking care of patients that come to the emergency department who are having chest pain and pressure, maybe even fevers, and they come in and you see ST segment elevation on the ECG, you're not going to know whether you're looking at a true STEMI versus whether you're looking at a patient who's got myocarditis. I showed you this case. This was our first case that we started with, sent in by Dr. Beal. This looks for all the world like a true STEMI. And when they took this patient to the cath lab, it turned out that this was myocarditis. So are there any factors that you can look at on the 12-lead ECG? Are there any things on the 12-lead ECG that you can look at and say, this is definitely a STEMI or this is definitely myocarditis? And the answer is no. Take a look at these two ECGs and I'll ask you, are these STEMIs or are these myocarditis? Both of these are patients that presented with chest pain and shortness of breath in the midst of the COVID crisis. And you need to decide, should you give thrombolytics to this patient or send this patient to the cath lab, or should you simply treat this patient as myocarditis? Now, when I look at this, say the top ECG, this looks like a STEMI, but there's not much in terms of reciprocal ST depression. So maybe this is myocarditis. And then looking at the bottom ECG, gosh, this looks really like a STEMI. There's nice reciprocal ST segment depression. And I would say the top one could be myocarditis. The bottom one clearly a STEMI. It turns out both of these were actually myocarditis. So when you look at literature, the electrocardiography literature, is there any way to tell the difference between myocarditis versus true type 1 STEMI? The answer is no. There is no reliable way of telling the difference. So the bottom line is you've got to make that distinction in the cath lab if you have access to the cath lab. So sure, when you see the patient, just send him to the cath lab. Easy enough. Well, if you have access to a cath lab, that is. Now, there's a problem. What we started hearing from many of our providers all across our community hospitals and in many other parts of the country and in other parts of the world is that when the interventional cardiologists were contacted and said, we've got a patient down here with an ST segment elevation ECG, we need to send him to the cath lab to find out what's going on, there was a lot of resistance from the interventional cardiologists because there's a lot of fear about that coronavirus, as we all are. We are all afraid of the coronavirus. And there's a lot of pushback from the interventional cardiology community. And instead, oftentimes they were saying, just give the patient thrombolytics so we don't have to expose our staff to the COVID patients. In fact, this was a letter and a report that came out of China early on, where the authors of this article were very strongly pushing towards just sending all of these patients for thrombolytics. And they actually proposed this very, very complicated algorithm. And just really quickly, what they said was essentially, if you have a STEMI, yes, it's possible that you may end up going for cath. But in this algorithm, the only patients that qualified for going for cath were patients that had contraindications to thrombolytics. If they had contraindications to thrombolytics, only in that scenario did they recommend taking the patient for cath. In every other patient, if there is no contraindication to giving thrombolytics, what they recommended doing in all of those cases was giving thrombolytics to these patients. And so this word of mouth disseminated, this publication disseminated, and a lot of cardiologists started saying, yeah, why don't we just give thrombolytics to the patients? In fact, this is a survey that was done amongst the American College of Cardiology membership. And you can see this was done March 31st. They said, if you have a patient that's confirmed or highly likely COVID-19 who shows up with what appears to be a STEMI, what do you think is the best way to manage these patients? And you can see that the majority of these physicians, these cardiologists, said, give them thrombolytics. Well, there's a problem with that approach. For the past 30 years, there's excellent literature which has come out, which has very clearly shown that percutaneous intervention, in other words, angioplasty or stenting, was clearly superior to giving lytics in terms of death, non-fatal infarction, stroke, hemorrhage, and also combined endpoints. In every possible outcome, intervention was better, safer, and faster than giving thrombolytics. So we've got 30 years of good research saying that PCI is better than lytics. So why would we want to take all of that literature and throw it away? So because there is this national and international debate amongst the interventional cardiologists, some of the major organizations, the American College of Cardiology and the Society for Cardiography and Angiographic Interventions, and also some of the European folks came up with similar consensus statements. And essentially what they came out and said, just very simply, is that primary PCI should be considered the standard of care. So the national organizations came out, and in Europe, they very strongly have been pushing for coronary intervention as well. Now, if you don't have coronary intervention, then of course you give thrombolytics. But if you have a choice, the best way to treat these patients, even if they're COVID positive or presumed to be COVID positive, the best intervention is still the percutaneous intervention and not the thrombolytics. They do acknowledge that some of these patients may turn out to be myocarditis, but the cath lab is still the best place to find out. Now, they talk a little bit about echo or point of care ultrasound, even coronary cardiac CT. And perhaps echo might be reasonable. CTA was not strongly recommended because if you send a COVID patient to CAT scan, you're going to contaminate the CAT scan, and that's going to shut down the CAT scan for quite some time. But echo was strongly recommended if it is available to look for wall motion abnormality, focal wall motion abnormality, which suggests a STEMI. But most places don't have echo. We, even at a very large academic center, we don't have access to echo in the middle of the night or on weekends. We have point of care ultrasound, but most of us as emergency physicians are not comfortable definitely saying this is a STEMI, not myocarditis, or vice versa. So even the national organizations amongst the cardiologists have come out very strongly and said the best way to take care of these patients and diagnose them is in the cath lab. And there's problems with thrombolytics. Think about this. If you give thrombolytics to a patient who has a true STEMI, up to 50% of cases fail. So even if you have a definite proven STEMI, thrombolytics fail to reperfuse in about 50% of cases. So what do you do with those patients? Those patients end up having to go for cath. So you're going to end up having to send these patients for cath anyway. Now, what happens if it's myocarditis? If you have a patient with myocarditis and you give them thrombolytics now, you're exposing them to all of the potential harms of thrombolytics with no benefit, the bleeding risks and everything else. And then on top of that, if it turns out to be myocarditis and you give thrombolytics, the ST segment elevation will not resolve. So you're going to assume that that's a failed thrombolytic case, and those patients will have to go for cath anyway. So the majority of patients, even if you give thrombolytics, you're going to end up having to send them for cath anyway. So just get the cath done right up front. That's what all of these national organizations and also the European Society have come out and said. We've got 30 years of good literature saying cath is the best way to care for these patients. Send these patients to the cath lab, all right? If possible, send a rapid test early so you know where the patient's going to go after the cath and so on. And if you don't have access to cath lab, in that case, it might be reasonable to give lytics and then transfer the patient for the definitive cath afterwards, right? What about post-arrest? Well, literature has come out over the past 5-10 years or so saying that if a patient has post-arrest STEMI, you should send them to cath. If they're presumed to be COVID positive, they've kind of put a halt on that. And the best thing to do is probably discuss those cases with cardiology. So it is completely acceptable to get on the phone with your cardiologist and discuss these cases as much as possible. Be very liberal in making joint decisions with your cardiologist. And also very, very importantly, we've become very good at using the personal protective equipment in the emergency department. Make sure the cardiologist and the entire staff upstairs are also using the PPE because everybody must remain safe. And so the cardiologists have learned to apply the PPE and all of them are using the PPE very appropriately as well, all right? Now, the last thing I'm going to talk about is cardiac arrest. All right, there are some new recommendations and guidelines that have come out pertaining to cardiac arrest. And this came out from Circulation, just some interim guidance about what to do when patients show up with cardiac arrest. And I'm not going to read through the entire article, but just to summarize key points. The major new recommendations with regards to what we should be doing differently with cardiac arrest all focus on the type of things that we should do to reduce the provider exposure to contracting the virus. So what are some of the things that we can do to decrease the risk of contracting the virus? Number one, before you go into that room to take care of the cardiac arrest patient, everybody needs to put the PPE on. This is not a time to be a hero and run into the room without the mask and without the gown. You've got to get gowned up. You've got to put the mask on. You've got to put the gloves. You need to take care of yourself and your staff before you go into the room, and also limit the number of personnel. There only needs to be maybe 3, maybe 4 people in the room. One doctor, maybe a nurse if it's a training institution, maybe the resident, one nurse for documentation, one nurse for doing the administering the medications. And then the other thing that can be very helpful to decrease personnel, if you have the mechanical compression devices, for example, the Lucas device, the automatic CPR device, apply that. We never use these compression devices until COVID hit. And now we routinely use the Lucas device, whatever other device you may have. Every time somebody comes in and needs CPR, we immediately get this device on, and that's one or two fewer rescuers that need to be in the room to do compressions. And the device can be very helpful as well. In terms of airway, there's a few important things that you can do to decrease the risk of aerosolization of the virus, right? HEPA filters for ventilation. Make sure that there's a HEPA filter on the bag when you're bagging, and also on the filter that's connected to the vent. What's a little bit unusual about COVID cardiac arrest is that the recommendation is to intubate early. Now, for years and years, we were never in a rush to intubate patients who were in cardiac arrest. But the guidelines now say, get the patient intubated early. You don't want to spend all the time bagging the patient, because bagging is going to increase aerosolization. So there's now a new priority. This is new in cardiac arrest. Try to get the patient intubated with the cuff tube and hooked up to the ventilator as early as possible. And of course, video laryngoscopy is preferable to direct laryngoscopy, because with the video, you don't have to be as close to the patient. And then the other change is that when you're doing the intubation, go ahead and pause compressions, because compressions are going to increase aerosolization into the face of the person who's trying to do the intubation, right? So two major airway changes. Number one, intubate early. And number two, for the intubation, pause compressions until the patient's intubated. We'll get them intubated and then resume compressions. Those are new in terms of what we do with cardiac arrest in the COVID era. Now, many places out there have talked about certain types of coverings. This is a clear box that was actually created. A lot of anesthesiologists are using this, and this presumably decreases some of the aerosolization, which would be going to the intubator. If you don't have a box like that, what you can simply do is get a clear sheet. That's what we do. We have a clear sheet. We just put it over top of the patient, and we do the video laryngoscopy under the sheet, under the clear sheet, and that allows us to do the intubation while minimizing the aerosolization. Right? What else? This is not the type of intubation that you get the first-year trainee who's never done intubations before, who just wants practice to do. This is a time where you need to get the patient intubated as quickly as possible so that you can get back to doing chest compressions. So the person who's doing the intubation has to be very experienced at it. For us, that's either the attending physician, the faculty, or a senior level resident, people who can get the intubation done very, very quickly, right? Try to avoid bag valve mask ventilation. As we said, try to get them intubated early. If you can't get them intubated early, it's probably safer for the entire staff to just provide passive oxygenation rather than bag valve mask ventilation. And also, if there's a delay, consider a supraglottic airway like what you're seeing up here, so that you can still protect the airway while minimizing the risk of aerosolization. All right. So again, key points are to protect the staff when they're managing the patient in cardiac arrest. The other point that they brought up in these interim guidelines is probably something which is appropriate for all patients, but it's become an even more important issue in the era of COVID. Consider the appropriateness of the resuscitation. The survival rates from cardiac arrest have always been relatively low, but in the setting of COVID, the survival rates are even lower. And when you have a busy emergency department and there's many, many other patients to take care of, and now you have a patient who is posing risk to the staff and also has a very low chance of survival if they're COVID positive, consider whether it's appropriate to conduct the resuscitation in the first place. And so this is a paragraph that they put in there. Again, I'm not going to read through all of this, but again, it makes the point that you need to balance your priorities of success versus the risk to the rescuers and also to the other patients. If you have your entire staff in one room in a patient who's in cardiac arrest, whose chance of survival is very low, while meantime you have many other patients who might have a much better chance of survival, if you distribute those resources to them, Well, unfortunately, this is a time where you might need to make some tough choices and not continue the resuscitation attempts for very long. All right, so let's just move on to some quick take-home points now, and then we can open it up to some questions. Again, there's three major ways that we're discovering that COVID increases the risk for cardiac problems. Number one, there's a marked increased risk for arrhythmias, especially related to the QTC. Number two, a significant increased risk for acute heart failure, largely attributable to myocarditis. And then number three, a significant increased risk for type 1 STEMI. And all of these have to do with this one word, inflammation. Inflammation increases the risk for QT prolongation. It increases the risk for that cytokine storm and heart failure, and it increases the risk for development of type 1 STEMI. And we'll hear a lot more about hypercoagulability in just a little bit. For ST segment elevation patients, follow your usual plan. Do what you always do, with one exception. Make sure that everybody is wearing the PPE. And then finally, with regards to cardiac arrest, manage the airway early, take precautions for the aerosolization, and make sure that you're doing everything possible to protect your team, right? I want to finish up with just a comment. This is a colleague, an intensive care unit colleague that I worked with for the first 6 years of my career. He works at one of our affiliate hospitals up in the ICU. Tragically, he contracted coronavirus about a month ago, and just this past Saturday, he passed away from coronavirus. And so just as a memoriam to him, I put his name up here, but this is also an important reminder to all of us that this coronavirus infection, it doesn't choose one person over another. It's completely random. It really is. And so we all have to take precautions, not just the patients with diabetes, not just the elderly, not just the patients that are obese. Everybody is at risk, and you never know what may happen. So we all need to maximize our ability to protect ourselves and our staff. All of us that are taking care, all of you that are taking care of these very, very sick patients, we think of as heroes. And I want to salute all of you for the hard work that you're doing. This is very difficult times that we are all involved in. I think it's been heartwarming to see the entire world come together as we try to fight this together. And I hope that a year from now, we'll be looking back on this as a bad memory. But we all do need to stick together and take precautions. And I want to thank you all for everything that you do in fighting this infection. And again, thank you all so much for giving me this opportunity to speak with you all today. And I'll open it up to questions, but thank you all very much.
Thank you, Professor Mattu. That's really one of the best lecture we ever have in cardiology COVID infection, you know. Few questions came up. The first one talking about the cutoff level of troponin in COVID patients, you know. Do you have a number, they said, a cutoff level?
There's no specific cutoff level. It probably depends on your lab. Whatever your normal cutoff levels are that you've always used are the same cutoff levels. In general, what we say about troponin is that any elevation of troponin is bad, and the higher the elevation, the worse it is. And so if it's just a little bit elevated, that's probably better than markedly elevated, but any elevation of troponin is going to be of concern.
Okay. Here's a question. One doctor is asking if we don't have a BCI center in our hospital and we have a suspected patient with STEMI, what's your advice for us?
If you have a suspected STEMI, again, just whatever you normally do with STEMI, if your normal pathway for treatment involves fibrinolytics, then by all means use your fibrinolytics. If possible, if it's possible to transfer that patient after the use of thrombolytics, I think that's helpful because, again, 40 to 50% of the time thrombolytics may not work and that patient will end up needing PCI. Or if it turns out that it wasn't a STEMI, but in fact it was myocarditis, those patients can probably be better delineated in the cath lab as well. So everything that you were doing before, just keep doing it, making sure to wear the PPE.
I see. Regarding the QT interval, Professor, If you have a COVID patient with the prolongation of QT interval, what's your advice to the intensivists and to the doctors regarding, number one, the medication they should avoid, and number two, the management of the patient?
Sure. So the QTC, excuse me, the QTC generally that we worry about is when the corrected QT, the QTC is over 500 milliseconds. Under 500 poses very little risk, not zero, but very little risk. Once that QTC is over 500, we monitor it closely to make sure it's not continuing to rise. We try to keep the magnesium and potassium kind of top normal, not at the lower end of normal, but we push it a little higher to top normal because hypomagnesemia and hypokalemia are very common in sick patients and in heart failure patients. So we want to keep those elevated. And if they're low, that'll prolong the QT. We might consider empirically also giving that patient some magnesium, again, trying to keep the magnesium level elevated, and also doing everything possible to avoid any medications that will prolong the QT. Typically, azithromycin, hydroxychloroquine. I think the literature on hydroxychloroquine is largely out, but there are many other medications that may prolong the QT. And so we would try to avoid those. If absolutely necessary, if the QT is rising, then again, empiric magnesium is going to be helpful. And if necessary, you can actually put the patient on a pacer and overdrive pace them just a little bit so that their heart rate is 100 to 120. Because remember, when the patient is a little bit tachycardic, that relatively shortens the QT. So the patient's in much higher danger. If their heart rate goes low, it's better, ironically, to keep their heart rate a little high, even if you need to pace them if their QT is getting longer.
I see. Really very impressive. Professor, regarding the controversial points of the early intubation versus using an early LMA, can you highlight this point again, Prof? Because it's I have some questions about it.
Sure. So the idea behind intubation early or getting a secure airway early in the cardiac arrest is that as soon as you have the patient intubated, it's going to decrease the aerosolization of the virus. And so you want to secure that airway with some type of balloon device early on. Normal endotracheal intubation with a cuff tube is probably the most protective. If you can't get them protected, you can use a supraglottic airway. That would be reasonable also. And once you have that airway in place, putting some type of shield over the face is going to be helpful also to decrease the aerosolization. So if you want to go to an early LMA, I think that's fine. And then just put a sheet or a large mask over the face so that there's not continued aerosolization. Either way would be perfectly fine. But bagging would be the worst case scenario.
I see. Thank you, Professor. This will conclude our topic. We have so many questions that I'll send it by an email to you.
Please do.
I so appreciate. We are so honored to have you with us tonight, and